So the role of ibrutinib at the moment in CLL is an interesting one. Certainly over recent years, it's been a game-changing drug in CLL and has been used an awful lot in the frontline treatment setting, particularly in the US, but in relapsed refractory disease as monotherapy in the UK and in much of the world. But with the advent of second-generation BTK inhibitors, certainly acalabrutinib has now been approved in the frontline setting and in relapsed disease, and has demonstrable efficacy and has a superior safety profile compared to ibrutinib. So when choosing a BTK inhibitor in those treatment settings, it certainly seems to be the case that acalabrutinib has some more favorable toxicity properties. So where does ibrutinib have its role? Well, we've seen recently data from the Captivate study and the GLOW study that the combination of ibrutinib plus a BCL2 inhibitor, venetoclax, in the frontline setting has clear efficacy, and perhaps using that combination in fixed duration, if it's approved in younger patients with high-risk genetics, it may be very appropriate in that group of patients. And then in the future, if CAR T-cell therapy is approved, we know that there's data accumulating with the product Lysocell, with or without ibrutinib, that it may be that ibrutinib is actually used to enhance the efficacy of CAR T-cell treatment in CLL. We know that patients who go through lines of therapy, their T-cell fitness actually reduces over time. And there's certainly some data to suggest that the use of ibrutinib alongside a CAR T-cell treatment may actually enhance the efficacy and the durability of CAR T-cells and their fitness. So we may see ibrutinib actually sort of shift spaces in the management of CLL over the coming years.